Hello and welcome to Health and Wellbeing, your trusted source of health information. And I am your host, Lois Apasambo. And today we bring you an important program on childhood tuberculosis. Tuberculosis, commonly known as TB, is a contagious bacterial infection that primarily affects the lungs. Sadly, children are not immune to this disease. And that's why today we will be discussing the national testing program aimed at detecting childhood tuberculosis early. We are being joined by Dr. Eko Edet, the Assistant Program Officer at USAID Breakthrough Action Nigeria. Thank you for joining us again on the program, Dr. Edet.
Thank you for having me.
And it's nice having you once again. It wasn't that far. So let's talk about it. Tuberculosis. So many people know it as TB, and it's mostly associated with the elderly, I wouldn't say elderly, but older people, and on rare occasions do we hear of tuberculosis in children. But we're beginning to see more cases, even though it's underreported. Let's start with, how do children with tuberculosis, children get tuberculosis? Is it the same way that adults contract tuberculosis?
All right, thank you so much for that question. I am Dr. Eko Edet with Breakthrough Action Nigeria. It's a United States Agency for International Development, social and behavioral change flagship project. And what we do essentially is to, promote priority behaviors around tuberculosis. To answer your question, tuberculosis is a serious public health disease. So Nigeria ranks 6th among 30 high-burden countries with tuberculosis, and is the first in Africa. All right, so that means tuberculosis is a big problem in Nigeria. And it also causes illnesses and death in children and adolescents. So it's a serious problem. And of course, children and adolescents get tuberculosis the same way adults do. But there is also the vertical transmission of tuberculosis from the mother to the baby. So we can have a rare condition called congenital tuberculosis, and there's also neonatal tuberculosis. So for the pregnant woman, it's through vertical transmission to the baby inside, the unborn baby inside the womb. And then within the first few months of life, of course, the child may also get tuberculosis from the mother. Okay,
just so for, I'll just say for the layman, just give us an overview of what tuberculosis is.
All right, so tuberculosis is essentially a bacterial infection. It's caused by a germ or a bacteria called Mycobacterium tuberculosis. All right, so it primarily affects the lungs, but it can also lead to other complications, what we call extrapulmonary tuberculosis, where it can affect the central nervous system, the spine, the abdomen, and many other parts of the body.
Okay, so we're talking about tuberculosis in children and tuberculosis in adults. Does it affect children differently in comparison to how it affects adults, or is it almost the same way?
Okay, so the signs and symptoms of tuberculosis are essentially the same, right? So there's usually symptom of persistent cough that has lasted 2 weeks or more. There can also be persistent fever lasting 2 weeks or more. And then we can have weight loss, all right? But for children now, adults could have an unexplained weight loss. But for children, what you would notice is that they are failing to gain weight, or they have a condition called failure to thrive. The child of 5 years is looking like a child of 3 years, so he's not growing as he ought to. So that is specific for children. But generally, weight loss, should draw our attention to the likelihood of tuberculosis, especially if it is unexplained. For instance, you have someone who has his trouser not, becoming too loose over a short period of time. That should raise suspicion. If someone has drenching night sweats, like maybe he has singlet on during his nighttime, and then wakes up with the singlet soaked with sweat, when every other person seems normal, that could also be a pointer to tuberculosis. And of course, people can have what we call hematemesis, that's coughing up of blood. They cough, and what they see, instead of seeing the sputum, they are seeing blood stains inside it. So that could also be one of the symptoms of tuberculosis. There are many others, weight loss, and all. So, yeah.
Because one of the things I noticed, the major, when people talk about tuberculosis, the first thing is someone that's coughing. Is it possible for someone to have tuberculosis and not necessarily be coughing for that long?
Yeah, so before now, people were fixed in terms of signs and symptoms, but we know too well that sometimes some conditions may be asymptomatic or may be atypical, in the sense that you may expect the person to be coughing, but the person is not coughing, rather is losing weight in an unexplained manner. So you don't have to necessarily wait for cough of 2 weeks or more before you say someone has tuberculosis. When you discover that someone has any of the symptoms I mentioned, persistent cough, persistent fever, unexplained weight loss, drenching night sweats, perhaps difficulty in breathing, an unusual weakness, with any of these symptoms I mentioned, then there should be that high index of suspicion, and those people should be, encouraged to go to a health facility for a test, a TB test.
Because one of the things that I noticed is, I'm just thinking, if we're going to base tuberculosis based on coughs, why do we still have cases, and the cases that are not detected, cases that are not even reported? And so it's very important that we make it clear for people that even when you're not coughing for, let's say, 2 weeks and it's not persistent as you would normally think, you also stand a risk of contracting tuberculosis. But we're talking about tuberculosis in children. What are the risk factors, that predispose children to tuberculosis?
Okay, so first of all, let's start with the younger, very young ones, maybe the neonates. All right, so if a neonate has a TB positive mother, that's a risk factor already, because the mother would have to be breastfeeding, stays with the child for a longer period. But if there is another adult, another caregiver around that child that spends a long time with the child and the person has tuberculosis, then that's one risk factor, So it's that prolonged, contact with an adult or someone older who has TB that predisposes the child to tuberculosis. And we find that tuberculosis transmission tends to happen more in congregate, setting, overcrowded settings, poorly ventilated places. So for people who stay, like you have like 3 or more or 5 people stay in one room, then the child is more at risk of having that. If there is a child in an IDP camp or a refugee setting, that child is prone to having it, because those settings usually have overcrowding. So any place where there are a large number of people, people suspected, presumed to have TB or with confirmed TB, then it is likely that that child may have that if he spends a long time with that adult and the environment is poorly ventilated. So those are some of the risk factors.
So you said something about asymptomatic, and when we say asymptomatic, let me get it clear. Sometimes it doesn't show signs.
Okay, so when I said asymptomatic, I was referring to some medical conditions not showing you symptoms. But I think much of what I was trying to explain was that you may not typically have the child cough for 2 weeks or more for you to say the child has TB. So if the child has any other symptoms suggestive of TB, like persistent fever that has lasted 2 weeks or more, like an unexplained weight loss, or the child is coughing up blood, or there's difficulty in breathing, so you should suspect tuberculosis, right? You shouldn't wait until it is cough alone. That's the point I was trying to make.
Okay, so let's talk about prevention, because prevention, they say, is better than cure, What steps can we take, to prevent our children from coming down with tuberculosis?
Okay. So I think we'll start with the adults, right? So you're with a child and you cough anyhow and you have TB. You are predisposing the child to having TB. So one of the things we emphasize is cough etiquette, right? And I think people were taught that even during the COVID-19 time, for people to cough into their elbows, all right, and then perhaps cough into a tissue and, properly dispose of that tissue. So those are the things we advise. And of course, places that are overcrowded generally, and, perhaps we would want to, avoid those kind of settings, especially, if there is a likelihood of transmission around that. Yeah.
Okay, so because we're doing this for tuberculosis, we would also have to dabble a little bit into policy. And just like we were saying earlier, tuberculosis in children is very underreported, is mostly reported in adults. And so sometimes you see children go to school, and as a parent, you don't know what your child meets there. You don't know who your child meets there. Are there like policies for managing tuberculosis in school? Having been like on the TB national program, are there policies or anything that guides management and treatment of tuberculosis in schools?
Okay, so I understand that there are certain documents with the National Tuberculosis, Leprosy, and Borreliose Control Program, that's the NTBLCP. And in fact, just this afternoon, I had to look again at that document. So there's a document on childhood and adolescent tuberculosis, which of course is very informative, and it's more like a desk guide to help health workers know what to expect, what they are supposed to do when they are faced with childhood and adolescent TB. And of course, we know when you talk about policies or laws, we know that children have the right to health. So what applies to the adult applies to the child, right? So but I don't know if you're specific with any particular policy, but the policy is that if a child, is suspected to have tuberculosis, then the right steps have to be taken. All right, so there has to be that high index of suspicion. They have to be screened. They have to be tested for tuberculosis. And if they are found positive, they have to be treated.
Okay. Yeah. So talking about treatment now, would we say treatment options for children are the same with that of adults, or are there separate treatment options for children? And putting it to notice anyways that we're not prescribing drugs for people to go and take anyways.
And I will not even mention the specific drugs.
Yes, but is treatment for children different from that of adults, or is it almost the same?
No, it's essentially the same. So it's a yes and no question, but largely yes. And I'll explain why I said no. So yes, in the sense that we're using essentially the same drugs for adults to treat children. No, because for children, it has to be adjusted based on the age of the child and the weight of the child. So, but in terms of the medications, they are essentially the same. But there are also slight differences in terms of treatment regimen. Okay, so we have some 4-month regimen, 6-month regimen, 12-month regimen. But generally, I would say the treatment is the same because it's the same drugs that is being given, just that the dose is adjusted per the weight and the age of the child.
And because we're in this part of the world where when people start taking medication and they just start feeling better, they abandon their drugs, And this leads to, if I'm correct here, resistance, illnesses getting resistance to drugs. And one of such resistance is tuberculosis. There are tuberculosis that are drug resistant, for children and for adults as well. So I'd just like you to tell us how drug-resistant tuberculosis affects children as well.
Okay, so as an organization and a partner of the National TB Program, we try to preach against, incomplete treatment or treatment, failure or something. All right, so we encourage people who are on TB treatment to take their drugs, to adhere to the treatment regimen. Let me make it more serious. For someone to, not transmit TB, it means that the person has to be on treatment for at least 3 weeks. So if someone is positive for TB within 3 weeks, like if the person is not on treatment, he can transmit it to 10 to 15 people within a year. Okay, so that's serious. But if you are on treatment for 3 weeks, that transmissibility, is no longer there. If you are treated for 3 weeks completely, you won't transmit it to other people. But that's not to say you should stop. Because if you stop, the organism will keep being active and then cause more problems. So we encourage people to take their medications, adhere to the medications. There is the intensive phase and there is the maintenance phase for over a period depending on the regimen. So we encourage them to completely take their drugs. I know it's not easy to do that, but we encourage that they try their best to do so, and we encourage family members and friends to support them to take their medication so that they don't transmit tuberculosis to people around them.
Okay, so what are the dangers of having, drug-resistant tuberculosis? What does this mean for people with drug-resistant tuberculosis?
Okay, so what it means is that you place the person on treatment and the person is not responding. What it also means is that the person can go on to, transmit TB to other people. So it's a problem. And we also have a way of treating drug-resistant tuberculosis. So when we find one, we treat it, and over a period of time, that doesn't necessarily become a problem anymore.
But do we ever have cases where somebody's tuberculosis is not curable, maybe after you've been treated for drug resistant, or you've been treated and then you didn't take it all, and then you've been treated for drug resistant? Does it ever get to the point where it has gone beyond repair?
Okay, so we've had instances where people completed their medications, and then were certified okay, they were fine, they no longer, had active TB, all right, but after a period of time, they were found positive again. And that's why we are, trying to raise the awareness of tuberculosis, so that as many people as possible are tested, and treated. Because if someone is in a house and then he or she is treated and is cured of TB, and another person within that house now has TB, it's likely that the person will reinfect this person. And if the immune system doesn't contain it, then it could progress again to active TB. So that has happened.
Okay.
We've noticed that before.
So still talking about children, what is like the long-term effect, for children that have had TB at a young age?
Okay. So I think the area I approach that question is the area of extrapulmonary tuberculosis. And one of it is that which affects the central nervous system. So you could have a situation where the person has what we call TB meningitis or tuberculoma, like there is a mass in the brain, or the TB actually affects them and causes symptoms similar to what we call meningitis. So the child may have things like neck stiffness, headache, aversion to light, and in some cases convulsions, and all that, and coma. That's unconsciousness and all that. So it can really be a problem if it is not just pulmonary, but now has affected another part of the body.
So what makes it get to that point? Because for me, that means this tuberculosis has become complicated.
Yeah.
What makes it grow to reach that point, because it's getting scary?
Okay, so it's simple. Perhaps because they don't have the awareness, so they don't even know it's tuberculosis, first of all. Or they know, but they have, either, first of all, they don't know, all right? And there's another one where people think tuberculosis is from witchcraft attack and all that, and they use, the religious angle to address it. Meanwhile, the disease, the organism, bacteria keeps multiplying and goes on to develop active TB, and the child has active TB, it is not treated, the child now goes on to develop the complications, the extrapulmonary tuberculosis. So it's a matter of low awareness, it's a matter of myths and misconception, it's a matter of perhaps fear of stigma, so people don't present to the hospital because they are afraid that others will run away from them. Maybe the child's classmates or the people around them will be afraid of the family and all of that. So fear of stigma can be another thing. And then, of course, those who are placed on treatment, poor adherence to treatment can also be the reason why the thing progresses to cause complications.
Okay, because it's very essential that people know about this and know the dangers of lack of treatment, how bad the situation can get. But now talking about prevention, still prevention, are there vaccines for tuberculosis?
In the child, like for newborns?
Yes.
Yes, that's why we have the BCG vaccine. The BCG vaccine is vaccine against tuberculosis. So we're giving that because the child could have tuberculosis from the mother or from any other close caregiver if they are not vaccinated against it. so that vaccine is available. Now, there's another thing that is available now. It's not a vaccine per se, it's a preventive treatment. We call it TB preventive treatment, that's TPT. And that's for both children, adolescents, and adults who have been exposed to a known, a confirmed TB case or a presumed TB case. So let's take, for instance, in a house, the father is positive for TB. And of course, we know that the children and the wife, they've been exposed, to that man. They've stayed with him perhaps for a long period. So they are likely to have tuberculosis. So what we do for high-risk contacts like that, we put them through screening and testing, right? And if they are negative for tuberculosis, then we place them on tuberculosis preventive treatment. So they are with someone who has TB, but they themselves don't have. So you are giving them, some treatment to prevent them from having, what the family member has.
That's right. Okay. So, in this part of the world, we like all the herbal things and herbal mixes, and you hear adults be like, there is more, how do they say it? They prefer natural things, herbs and all of that. But I'm not talking about the herbs now. Are there dietary or nutritional, nutritional diets for people that have had tuberculosis, in the management of tuberculosis?
Okay, that's a very good question, actually, because malnourished children and adolescents and even malnourished adults are more at risk for tuberculosis, right? So there is the part where diet comes into play. But of course, we know that once you're on treatment for TB and you are on good diet, we're not specifying. I know that the nutritionists have specific diets to manage malnutrition, especially if it's severe acute malnutrition. So they have certain things they give, plumping nuts and all that. But for tuberculosis, if you essentially treat the tuberculosis and the person is, having the regular balanced diet, we expect that over time the person improves. Like we've had a success story where someone in the community where we do our community-based level activities was found to be positive for TB. He had unexplained weight loss. You could see his ribs. But that same man, we went back after a few months and he was totally different. So he wasn't exactly receiving a special diet per se, but he was compliant with his medications. And he was, of course, eating the regular food, good food at home. And over time, he became healthy looking again.
Okay. So as part of the National TB program, I'd like us to talk about how people can have access to treatment. Because it has always been on the news. I don't know why sometimes people just don't get it. Tuberculosis treatment is free, but people somehow, I don't understand how it happens, cannot access it. How can people access TB treatment?
Well, I think we can understand it a bit because, first of all, we have issues with poor health-seeking behavior by, the masses. Two, we have issues with distrust in the health system, and perhaps, fear of weakened health system. So people are like, is it truly free, as they say? But I can confirm to you right now that tuberculosis testing and treatment in accredited health facilities in Nigeria is free. And what we have done in collaboration with the National TB program is to have a unified campaign. It's called the Chekamo campaign, right? Where we use the social media, the mass media to encourage people, to test for fever, to test for tuberculosis when they have cough of 2 weeks or more, or other symptoms that I mentioned earlier. So that we have a national toll-free line that can be used for that. It is for the masses to call 3340 or dial star 3340 hash. Okay, so when they do that, they will get information about tuberculosis and they will get information about the nearest designated health facility where they can access their free testing and treatment. So tuberculosis testing and treatment is free in Nigeria. So we encourage the masses to make use of that unified national toll-free number, to reach out and then get tested and treated for tuberculosis.
So, talking about having to deal with tuberculosis, in the entire TB program, it should not be just about treatment. You know, are there counseling groups? Are there support groups for people with tuberculosis where they can share, you know, issues that they face with tuberculosis?
Okay, yeah, we're actually, currently looking a lot into that. Okay, so what we've done so far as an organization and as a national program is to, counsel healthcare workers on how to do interpersonal communication and counseling. So it's not just the regular aspect of, just telling someone to go do a test and the person comes by and you say you have tuberculosis, go and take these drugs. No. So we've trained these health workers to be able to, and will continue to do so, to be able to, provide appropriate counseling. All right. So we believe that much of the treatment adherence issue can be handled when there is proper counseling by the healthcare worker. And support groups, yeah, that's a laudable intervention. And I can't say to you right now for sure if there are specific support groups, but I know that that's actually part of the discussion so far, to ensure that people with tuberculosis have, a group where they can share experiences, and encourage themselves, to take their drugs and become better.
Yeah, speaking about the support groups, is because of the stigma attached to tuberculosis, and that's why sometimes some people cover up when they find out that they have tuberculosis. So are there interventions, on enlightening people on, no, this is what tuberculosis is, you shouldn't stigmatize people?
Yeah, so we have, recently we started training certain persons, including the national call center people, the 3340 I told you about.
Okay.
Yeah, so because we know that stigmatization is a big problem for tuberculosis, and so we started training them on, stigma. And now we train them to understand that stigma is not just from outside people, it can even be from the TB patients themselves, where they feel, oh, because I have this, I shouldn't, like they first stigmatize themselves before even other people stigmatize them. So we're doing that training, and I'm pretty sure the training is going to be, is going to continue. We're trying to preach around, not stigmatizing people with tuberculosis, because of course it is preventable and it is curable, and once they've been on treatment for 3 weeks, they don't transmit it anymore.
Okay.
So there's that approach already, that intervention, already.
Well, so where would we draw the line between stigma and isolation? Because, we also had that issue with COVID where when someone had COVID, you had to give the person distance, and even with tuberculosis, because mode of transmission is almost the same. So where do we draw the line between, okay, this is prevention and then this is stigmatization?
Okay, so I think that line is thin right now. So all we'll have to do is to thicken that line, and perhaps over time, do something about it to ensure that people are not stigmatized, not isolated. You don't essentially have to isolate a TB patient. What you need to do is to ensure that the preventive measures are put in place, all right? So once that is done, you don't have to stigmatize the person. You don't have to isolate the person, So it's not like COVID that people had to be kept in a particular center to be treated. No, not at all.
Because with tuberculosis, I remember when we were small, we don't use the same cups, we don't use the same spoons, So it's almost like, what's wrong with me? Why are people not using my cup? Why are people
yeah,
not?
So thank you for raising that, because one of the things we discourage is people thinking that tuberculosis can be gotten by sharing utensils at home. So you don't get tuberculosis by sharing utensils at home. No, you don't.
Okay, I would need more explanation on that.
Yes.
Because mode of transmission, could be like if I cough, and that means that there's some phlegm or whatever that comes out from the mouth. So if we're sharing the same cup, isn't there like a possibility, that if I have tuberculosis and I drink from this cup, I may have left some remnants that if you use that same cup, you may have.
So you know that tuberculosis, we said pulmonary tuberculosis, so it affects the lungs. And if you notice, when we are taking samples, we don't take sample of the saliva. The person has to cough up the sputum from the lungs, for us to test. So merely sharing utensils cannot give you, tuberculosis. Yes, it's a pulmonary condition, not a mouth or something.
Yeah, because that explains it a lot better. Because I remember when we were young, those were part of the things in prevention, anyways, and somehow people just felt bad, felt discriminated against. Like, okay, why do you have to? It's almost like your own is kept separate, and we don't use that one. So let's talk about what USAID Breakthrough Action has been doing. In tackling tuberculosis. We're on the race to ending tuberculosis by 2030. Is that possible?
Oh, well, anything is possible. We'll continue to try our best, and that's why people set targets. When targets are set, you either meet the target, exceed the target, or you go close to the target. So as Breakthrough Action Nigeria, we're working with NTBLCP to ensure that we increase case finding, like we need to get more people, with confirmed tuberculosis so that they can be put on treatment. And as an organization, what we've been doing, we've used different approaches. We've done in communities, what we call motorized campaigns. So we used hotspot mapping, like a mapping of areas where there's a likelihood of TB, maybe overcrowded places or places with high known cases of tuberculosis. So we do motorized campaigns. We go with speakers, and like speaker on a vehicle with our banner, we had social and behavior change materials, SBC materials, where we raise awareness of TB, draw the attention of people and then talk to them about TB, and then encourage them to come for screening and for testing. So through that intervention, we've been able to get positive cases from the communities. Another thing we do is targeted community outreach, where we go to a particular community, and of course we do that with our service delivery partners, those who have the capacity to conduct the test and all that. So we go there and tell people about tuberculosis, the cause, the transmission, the treatment and all of that, and encourage them to do tests. Yeah, and another way we've helped, in fighting tuberculosis is to engage patent and proprietary medicine vendors, what people commonly know as chemists. And whether we like it or not, those people have the trust of a lot of community members,
Very
and they
true.
even call them doctors, So, and most times when they have cough, of course, they go and take treatment, they ask for medications, So being that they are trusted people in the community, we also give them, the sensitization, and encourage them to tell people who keep coming to buy antibiotics for cough, people who have cough 2 weeks or more, to go and test. That the fact that they've treated with antibiotics and they are still coughing means that there's still something they've not found out. So through that, we've been able to get lots of cases too. And another influential people we've found and we've engaged is religious and traditional rulers. So we've been able to engage them. They have good knowledge of TB now, I can tell you. And so they use some of their mosque and church, services, activities to tell people about TB and to encourage those with, suggestive symptoms to, go for tests. And what we even did was to give some of them what we call simplified referral tools. So when they have people who think they may have TB based on what they have told them, they now write that, some referral, and the people go to the health facility and they get tested and treated. One other thing we do is unions and civic organizations, people like National Union of Road Transport Workers, all these parks and all that. So we take our activities to them. We engage them first of all and tell them about our intentions, and then we carry out activities in those places. So through that too, we've been able to get cases. Yeah.
Okay, so and that's great because Nigeria has upped its case finding to I think about 70%, and that's a good one. But we want to get as many as possible, because we're on the road to ending tuberculosis as much as so many of the diseases in the country. Yeah, but generally looking at the national TB program and how Nigeria is, would you say that Nigeria is well prepared? Funding, let's talk about funding. Is funding available? Is it readily available? And the one that is readily available, is it used right, in the journey to end the TB?
All right. So the outright answer is no. There is definitely a funding gap. Funding is a big problem in Nigeria. We currently have a funding gap with regards to the TB program. I already reeled out, some of the activities that Breakthrough Action does in partnership with the National TB Program, and that's not in even all the states of the Federation. And being a USAID-funded project, we know how much goes into the TB program. Now, if you want to look at the whole country, and implementing all these approaches, that it is, cost intensive. It costs a lot of money, to implement TB programs. So to achieve our target, you mentioned 70%. I can tell you that the other time we had a target of 200 and something thousand cases, but currently we have about 300 and something thousand. So that means that we have to optimize the approaches we are using, the implementation activities and all of that. And if we're to do that, it means that funding is very important. And currently, that level of funding does not exist. And that's why we are working, tirelessly, to encourage domestic resource mobilization. We're trying to make people at the federal, state, and local government levels, to, increase funding for tuberculosis. And for those who are not funding, to do something about it. We're encouraging the private sector, corporate organizations, as part of their corporate social responsibility, to also fund tuberculosis programs. So that gap exists, and we're hoping that we'll be able to fill that gap.
Well, thank you very much, Dr. Edet, for taking our time to be here with us on the program. But before we end, we'll be talking about childhood tuberculosis. I'd like you to give a word of advice to our parents out there in regards to, tuberculosis in children and how they should take care of their children.
Okay, so one simple message is that tuberculosis is a serious problem in Nigeria, and it causes illness and death in children and even adolescents. So children are not spared from having tuberculosis. And so we encourage you, if a child around you is coughing for 2 weeks or more, having persistent fever for 2 weeks or more, if your child is failing to gain weight, not growing as the children within his age group are growing, of course you need to suspect tuberculosis. And if the child also has things like coughing up blood, the child is weak, difficulty in breathing, or any unusual symptom you don't understand, perhaps the child is having swelling on one side of the neck for more than a month and you don't understand what's going on, please, you have to take the child to a designated health facility for free testing and treatment. And we've made it easier now for people, to be able to access this free testing and treatment. All you need to do is to call 3340 or you dial *3340, and with that you'll be able to receive information about tuberculosis and where you can access free testing and treatment for tuberculosis. And for mothers who have just given birth, please ensure that your child takes the tuberculosis vaccine, what is called the BCG vaccine. Thank you.
Thank you very much, Dr. Edet. We sincerely appreciate your presence on the program. Thank you so much.
My pleasure.
Well, it's time to wrap up our program today. But remember, early detection saves lives. If you suspect your child may be at risk or showing symptoms, do not hesitate to reach out to a healthcare professional. Together, we can prevent the spread of tuberculosis and protect the health of our children. Thank you for joining us today on the program. And to stay informed, do stay healthy. We'll see you next week, Thursday, by 5 p.m. on another episode of the program. And if you have contributions or questions, you can reach out to us on the social media handles scrolling on the screen. I am Lois Appasambo. Do stay safe.